Good evening and a warm welcome to all of you. I am Dr. Sharmin, the CPD coordinator for the Young Doctors, for the Spice Route Young Doctors movement. And today actually marks an important day for Spice Route as we resume the GP's Café. I kindly invite Dr. Gobit Ratnasingham, Chairperson Spice Route Young Doctors movement, to give an introduction about the GP's Café and about our cause. Over to you, Dr. Gobit.
Thank you, Dr. Sharmin. So good evening, everyone. So you all know, so we had commence a GP Cafe called CPD program, actually mainly targeting and we'll mainly run by the young doctors in Sri Lanka. Actually, this has started in 2019. First session has started as a physical session. Then from the second session, so we started as a hybrid. You all know that nowadays we are very maybe with fortunate or maybe annoyed with the Zoom sessions for the every day. But even though before the Zoom era in the 2019, so we had with Google Hangouts and Google Chat, we have started our webinars through that even in the 2019. Then after the continue around 17 sessions, actually some are in the physical session, some are as like a Zoom or maybe in the other webinar sessions. We have discussed very interesting cases, mainly by the young GPs and trainees, and sometimes we are collaborate with the senior members, and even few cases we have added with some non-medical, even tax and other topics as well for the which are very important to our daily practice. So I'm very happy to talk about and about this GP Cafe. Actually, this GP Cafe from the collaborate with the College of General Practice in Sri Lanka. It's with the physical one. Actually, we can have the CPD points. But anyway, so as a Zoom one, so still we are not providing, but still we will have the very good discussion and gathering and the fun during this session. So not only the clinical cases, sometimes because clinical pearl and other some short descriptions and all we will discuss. So we will go ahead with the discussion. Before that, so I just show or little bit I'll describe about the Spice Route. What's the Spice Route? Actually, you all know the World Organization of Family Doctors, WONCA. WONCA is the main parent body for the family doctors around the world. From that, with the young doctors movements are there. From the each region, for the 7th region, we have the 7 young doctors movement. From the Southeast Asia, we have the Spice Route. From that, we are the member from Sri Lanka. We have the Spice Route Sri Lanka. So we are the young members are here. So you all can join. So we will share the even application. Actually, there's a small application about this Google Forms. This is about Spice Route, and we have the barcode, so you can scan or we can get the screenshot for the next slide, please. Next slide, please.
Yeah, 1 second.
Yeah, sure. Anyway, you can contact us to how to join. There's a small Google form is there. Actually, this is free of charge for the application. You can join. So we go through the application and we will call you also. You will contact with us. Actually, we do a lot of programs, not only for the GP Cafe, other educational activities and social activities, even the collaborating with the local and international conferences also. Even so, the October 2023, we are going to have a WONCA World in Sydney. So even young members are participating from Sri Lanka. So that's from my end about the description. So Simon, you go ahead about the topic. Yeah.
Okay, thank you, Dr. Gobit. That was very enlightening. The forum is now ready for our case discussion. And before we proceed, I would like to inform you that we would like to keep this very interactive. And so all questions are welcome. You can even send your questions to the chat box. Before introducing my speaker, let me quote, "Knowledge is treasure, and it is the only treasure that increases when sharing." And I'm privileged to introduce my guest speaker today, Dr. Prabhath Nanayakkara, who is very, very enthusiastic about his case today, a bus driver who cannot overtake. So Dr. Prabhath graduated from the University of Colombo, and prior to obtaining his DFM in 2019, he worked as a medical officer in multiple units from like blood bank, cardiothoracic, anesthesia, and pediatric cardiology. He is also currently a registrar in MD family medicine and an MCGP trainer. Over to you, Dr. Prabhath.
Thank you very much for those kind words of introduction. I think you can hear me clearly.
Yes, we are.
Yes.
Okay, I'm sharing the screen. So, certain professions are looked down upon by the society. One such profession is private bus drivers. Actually, when I drive along the baseline road, in my left side, I can see a slogan along a wall, "Sirakaruvoda Manushya." And it's like that. I think private bus drivers are also humans. That sound, is it a gun clicking?
I don't like bus drivers. They are like a menace to the society. They are so inhumane.
Yeah, that's the usual way of perception about the private bus drivers. Actually, about today, I'm going to present you about a patient I have recently encountered during my MD training at the neurology ward. A private bus driver who cannot overtake. So he is Mr. HG, a 65-year-old male, a private bus driver for 35 long years, who was diagnosed with diabetes mellitus 5 years back and under the follow-up of a GP. He presented with double vision when looking at left side for 1 month. So I think you can obviously know why he can't overtake. He's seeing all the lines as double. And so at this point, I would like to start up the discussion. So what can be the reason for his double vision? What are the differential diagnoses? You all can contribute.
Left-sided 6 nerve palsy.
Okay. What else? Okay, when we consider differential diagnosis, we can go in a systematic way. And also we can, as GPs, we must consider the probability diagnosis as well as we should not miss certain things. So when we consider commoner things, the commonest things are physiological. Even when we focus at a small thing, a short distance, we can see double. Another commonest thing, I think you all know it, I will tell later. And the other things are strokes, head injuries, trauma, or even sometimes occasionally mononeuropathies like diabetes, multiple sclerosis, or diseases in the orbit like hyperthyroidism, Graves' disease can cause this diplopia. And also things like cataract can cause double vision. We must not miss strokes and tumors as general practitioners. So these are the differential diagnoses in order according to the place of arisal, orbit to Pons, but I don't go into details of this slide because it's very tiresome to memorize all these in order. So as I told earlier, so that commonest cause of diplopia is intoxication. So it's a Saturday night, friends, and you may explore whether diplopia is occurring tonight. And turning back to our patient, he developed severe headache on 3rd of November. He can remember exact date and time. He was walking to his paddy field. It was an off day for him. And then followed by a slight difference in vision and numbness in the left side of the face. Those were the main reasons he encountered us. And his headache was sudden onset. And he can remember he got it in the morning and increased to maximum severity within 1 hour. And it was 8 in the pain scale and resolved partially in response to paracetamol. His double vision developed over a few hours on the same day. He first sensed it in the evening, but he was not sure whether it's double vision. He sensed some difference. And when it came to next day morning, it was affecting his vision badly and he couldn't go to job. And that was the last day he drove his vehicle. And this occurred only when looking at the left side. When closing one eye, the vision became normal. So when I inquired, the images separated horizontally. And from that evening, he has facial numbness around the left eye. It was over the forehead and over the cheek. And there was no weakness. He could chew his food and he could swallow easily. There was no problem in mastication or swallowing. He was a diagnosed patient with type 2 diabetes for 5 years. And he had a clinic book with him belonging to a GP. He was going to the clinic. He had records available since August 2020 for 2 years. And he had 8 GP visits. And this is the summary of his GP visits from the available details. Total cholesterol was done in the first visit. It was 158. And serum creatinine was done twice, including the last visit. It was normal. And fasting blood sugar checked all the 8 times. And blood pressure was measured all the times. And there were gaps in visits. The longest gap was 7 months without seeing a GP. So I inquired about the complications of diabetes in him. And he had some evidence of retinopathy. Vision was mildly reduced and he had some mild cataract. Also, he had numbness in soles for 1 year. And I suspected this episode may be a stroke. So he had macrovascular complications also. In the dietary history, I noticed that he is not adherent to diabetic diet. He is having many cups of plain teas with sugar. And he was not eating much vegetables and a lot of rice included in his plate of diet. And he was very occasionally using alcohol and he's a non-smoker. His family history was insignificant except that his brother is a diabetic. And in the social history, though his driver job is at stake due to this illness, he has additional income from a paddy field, which he rented to people. And his wife is a postmistress who was retired and on a retirement salary. And his 2 children are grown up and they are not dependent. Actually, younger one is hoping to go abroad for employment. So this was the scenario of Mr. HG. And his general examination was normal, except that I noticed a squint. So during examinations, I noticed that 5 and 6 cranial nerves are affected. These are the photographs of actual Mr. HG. And you can see in the first photograph, he is looking directly, and there is a slight medial deviation of the left eye. And in the second picture and fourth picture, both, you can see that when he is looking towards the left side, his left eye is not moving. It's in the center position. It's not actually center, a little bit inclined to a left side. It's because he is compensating with the rectus oblique muscle. And in the third picture, you can see when he is looking at the right side, his both eyes are directed towards right. So this is obviously a sixth nerve palsy. And I tested for trigeminal nerve and found that there is sensory loss over maxillary and ophthalmic divisions of the trigeminal nerve. So in conclusion, the only sensory part of the CN cranial nerve 5, 1 and 1, V2 are affected, and the sixth nerve. So in any neurological diagnosis, there are two major questions we ask. What is the lesion? Where is the lesion? So I would like to ask you those questions. Can you think of where the lesions would be? Since this is a discussion, I would like to invite you all to answer.
Hello. So in this patient, the left side sixth nerve is involved, and also the sensory part of the ophthalmic and maxillary divisions, isn't it? Fifth nerve. So so it is not isolated cranial nerve palsy, difficult to say. So I suspect a lesion is at the brain stem.
Yeah, that's one possibility. Anything else? Okay, this is how
at the cerebellopontine angle.
Yeah, that's possible. Cerebellopontine angle is one possibility. Yes, very good. So I tried to work out. When I read about this case, the diplopia can occur. In diplopia, we can work out the lesion by history and examination alone. So one question I had was, can a double vision occur in a mythical one-eyed giant, a cyclops? So if a patient is one-eyed, can he have double vision? Actually can. There is monocular diplopia as well as binocular diplopia. Then I read more. There were committant and incomittant diplopia as well as vertical and horizontal diplopia. So the monocular diplopia occurs even when one eye is closed. It is usually due to a problem in that eye itself, and it's due to intraocular pathologies. It's rare. The common scenario is the binocular diplopia, which occurs only when looking with both eyes, as that happens in Mr. HG. So the monocular diplopias can occur in irregular astigmatism, that is corneal irregularities, and displaced lenses or poorly fitting contact lenses, and even early cataract. Mr. HG had early cataract, but he had binocular diplopia. So I thought it might not be the cause for diplopia in Mr. HG. And also the presentation was a bit acute. And the binocular causes, we listed most of them. It's in the slide: cranial nerve palsies, myasthenia, strabismus, orbital trauma, stroke, etc. So then there are committant and incomittant diplopias. Committant diplopias do not change the direction of the gaze, but in as in Mr. HG's case, it is an intermittent diplopia where the diplopia occurs only when looking at a certain direction. This is usually due to ocular muscle palsies. And then the vertical and horizontal diplopias, depending on the separation of the images. Two images, they may be horizontal or vertical. Then this vertical and horizontal separation is due to the paralysis of either vertical muscles or horizontal muscles. The superior or inferior rectus, which are vertical muscles, when one of these are paralyzed, then vertical diplopia occurs. It's usually rare. And the horizontal diplopia are common. It is due to medial rectus or lateral rectus palsy. And also I have to add that oblique or torsional diplopia can occur, especially in oculomotor palsy. The images are separated obliquely. In this graph picture, you can see how diplopia occurs in Mr. HG by unopposed action of the third nerve. Now this is the left eyeball, and due to the paralysis of lateral rectus muscle, the third nerve, medial rectus, pulls medially. So in a direct gaze, his eye is slightly rotated medially. But when he looks to the left side, his eye moves slightly to the left because of the action of inferior oblique, the oblique muscles. So the sixth nerve palsy, as you can remember, the famous mnemonic we use is LR6 SO3. The superior oblique is applied by trochlear nerve, lateral rectus is by sixth nerve, the abducent, and the rest are by the third nerve. So abducent nerve palsies most commonly are due to idiopathic causes, followed by neoplastic as well as microvascular ischemia, and some are other causes. So this is the pathway of sixth nerve. It's in the deep part of the pons, arising in the nucleus, and goes forward to emerge from the cerebellopontine angle, just medial to the facial nerve. And then it runs forward over the petrous temporal bone and along the cavernous sinus wall, and enters the orbit through superior orbital fissure. So here I saw an important and very interesting association. The ophthalmic nerve, abducent nerve, and maxillary nerve are closely related in the wall of the cavernous sinus. So in Mr. HG, can this be the site of injury? What can you say about that argument?
In the case of a cavernous sinus thrombosis,
Yeah,
or
cavernous sinus pathologies can give rise to,
or a mass,
can be
space of
yes. Yeah, those can be the cause of. So can this be the site of injury? So what are the pathologies at cavernous sinus? It may be a tumor pressing from the lateral side, or cavernous sinus thrombosis, fistula, aneurysm, or dissection. But usually these are associated with ptosis, Horner syndrome, or fundus. At the fundus examination, I would have seen papillideme. So this is the spectrum of cavernous sinus pathology. It can be as severe as this case of cavernous sinus thrombosis, where bilateral severe facial edema is seen, or present as unilateral redness, simple ptosis, because trigeminal nerve carries the autonomic nerves, autonomic nerve ganglia, or just papilledema without any external deformation. But in this case, there was neither. So I thought it is a possibility, but a remote possibility. So a CT was done, and a CT revealed the pontine infarct, a large one. So that must be the cause for this picture. So, and I have to admit that there's a delay of about 2.5 weeks for this CT from the onset of symptoms. There was a patient delay as well as the doctor's delay, and he was seen by a specialist and then by an eye surgeon and then referred to a neurologist. So he came a long way to get this CT and to get a diagnosis. That is one place I would like to highlight. As GPs, we should refer these patients earlier. The headache was the initial presentation. We have to suspect a headache can be a sinister cause in a patient like this, because he was obviously describing it as a something never he had experienced before. Prevalence of a stroke in Sri Lanka. There was a study done in 2015, and it's showed that 10.4% per 1,000 people, and it is rising. The trends are rising, with more males are more affected, and most prevalent risk factors are hypertension, smoking, alcohol use, type 2 diabetes, and past history of TIA. So in this case scenario, I had several things to discuss. Diabetic management, management of stroke in the community, and primary prevention of stroke. Of all these, I thought of limiting my discussion to primary prevention of stroke in the community as GPs. There are non-modifiable risk factors for stroke like age, low birth weight, race, genetic factors. Especially if a documented parental history of a stroke before the age of 65, there's a higher risk. But we are more worried about modifiable risk factors in primary prevention. Physical inactivity, dyslipidemia, diet, hypertension, obesity and diabetes, cigarette smoking, atrial fibrillation, and as well as other cardiac conditions like valvular heart diseases. All are modifiable risk factors for a stroke. We have to identify these risk factors in a patient and do the certain management. So in this patient, what else would have been done? I would like to open the discussion regarding this point, but I have to mention that this is only for academic purpose. This is not a criticism, but it's just to improve our knowledge and share this knowledge. So this is the summary of his GP visits. You can communicate and you can come out with the things what you would have think being done to Mr. HG from the onset.
Just looking at this table, what is very evident is the impaired, like poor glycemic control. And despite that, it's only metformin 500 twice a day. And little has been done to, either increase or change the medicine.
Yes. Any other ideas?
And in this patient, only the total cholesterol has been performed.
Yes.
The lipid profile should have been done to assess the cardiovascular, 10-year cardiovascular risk and all.
Yes, very good. Other things?
But Dr. Prabhath, whatever it is, the patient company is poor according to this chart. For the 2021, he has visited only two times. So his GP. And
Yes.
in 2020 only 4. With that
Yes.
scenario, it is difficult to optimize a patient even. I mean, if
Yes.
the doctor is how much vigilant or how much dedicated, it is
Yes,
difficult
exactly.
to find the patient compliance. I mean,
Yes.
that's also a possibility, I think, in this patient.
Yes. So there is it's not always doctor's fault. If the patient is not coming to the follow-up, doctor can do nothing. Yes, that's
And
very true.
one thing that anyway, even the patient didn't go to doctor, that doctor should have asked him to at least after 2020 up until 2022 to get done lipid profile, because LDL we have to monitor closely, right? With diabetes, it causes it increases severe risk. And I mean, with all due respect, is this a pontine infarction or hemorrhage?
Actually, it was an infarct, but when what I posted was the second CT, there was small hemorrhages. Yes.
So
Yeah.
can't it be a aneurysm-like thing?
No. The first there was a first CT which was reported, but I couldn't take a photograph. It was a ischemic stroke, and thereafter, the second one was reported as there was small hemorrhages. He was
Okay,
not.
no, I was thinking aneurysm because he was complaining of thumping headache early in the morning, right?
Yeah.
And maybe with vomiting.
Yes, he didn't have vomiting.
Okay.
Yeah, thank you for that input. So, so I mainly focused on glycemic control, what should have been done, and dyslipidemia management, and about the diabetic follow-up plan. So, in his glycemic control, fasting blood sugar range in this patient was 125 to 166. He has not undergone any HbA1c. The most recent ADA guideline says it's better to perform HbA1c at least twice a year. And I think it's affordable to most of the people. And according to the economic status of Mr. HD, I think it's mostly affordable. So HbA1c was not done. And PPBS also should have been done. What's your experience about PPBS in follow-up of a diabetes patient? How do you perform fasting blood sugar and PPBS?
I think HbA1c combined with PPBS gives a much more clearer and image on control rather than doing fasting blood sugar.
Yes, exactly. In HbA1c, actually, if the HbA1c is higher, the PPBS contributes more to the HbA1c. If the HbA1c is lower, it's the fasting blood sugar that contributes more to the HbA1c. And the studies suggested that intensive therapy with drugs and intensive control of glycemic control, intensive glycemic control reduced myocardial infarction and all-cause mortality, while there is no change in stroke risk. There were many trials, including UKPDS and ACCORD and advanced trial. One trial in a recent meta-analysis showed that there was a beneficial effect of tight glycemic control in diabetics with BMI more than 30. But we are not preventing only strokes, we have to prevent myocardial infarctions also. So ADA guideline suggests to have a HbA1c target of less than 7, mainly to prevent microvascular complications of diabetes. It is level 1 A evidence, class A evidence. So very strong evidence to have a HbA1c target of less than 7. And lower HbA targets can be tried depending on doctor's judgment and patient preference, as well as the absence of hypoglycemia. And there was expert evidence that expert experience that setting a glycemic goal during consultation improves outcome. As GPs, we should educate the patient about the glycemic goal always. Then they will know what they have to achieve, and it will also improve the compliance. So in addition, in the dyslipidemia management, now people like Mr. HG need primary prevention of stroke and cardiovascular events. So we calculate the cardiovascular disease risk using many cardiovascular risk charts: WHO, ISH, ACVD, and SCO. SCO is for European and ACVD for Americans. And we have a WHO, ISH cardiovascular disease risk assessment chart, which is made using our data. Sierra B region chart is for us. And there are other risk factors like obesity, physical inactivity, psychosocial stress, autoimmune diseases, family history, and social deprivation. So in the management of diabetes, in the primary prevention of cardiovascular diseases, what they recommend is all the people in the age group of 40 to 75, moderate intensity, at least moderate intensity statins should be started, because diabetes, and also in Sri Lanka especially, South Asian origin is a risk factor for cardiovascular disease. Now AHA is including that. So all the people with diabetes, we have to do a lipid profile, get the baseline LDL level, and then have the LDL target. For those people at the age of 40 to 75 without any risk factor, LDL target is 100. And if there is at least one risk factor, LDL target is 70. So being a South Asian person, the LDL target goes to 70 automatically. So it's imperative that we all should perform. We all should know the baseline LDL level of any diabetic patient we are managing at our practices. And for the elderly people, more than 75, if they are already on statin, we have to continue. And if we are planning to start statin, we can start moderate intensity statins, but we have to start from lower doses and slowly step up after explaining risks versus benefits. So this is the European treatment goals. It shows that there is no cutoff for lipid profiles. It's only the cardiovascular risk. We have to assess the cardiovascular risk, and we have to, according to the cardiovascular risk, we have to set the LDL targets. So in any diabetic, as I said earlier, have a moderate risk. And if there is a risk factors, risk increases to high. And if there is a attack like this, the risk becomes very high, and the LDL goal further lowers to 55. So in Mr. HG, the LDL goal is 55 milligrams per deciliter. So we have to know the moderate intensity and high intensity doses of statins. Usually moderate intensity is atorvastatin 10 and 20, rosuvastatin 5 to 10, while high intensity is atorvastatin 40 to 80 and rosuvastatin 20 to 40. So we are usually starting with atorvastatin 10, and we can step up gradually because some people experience side effects with the higher doses of statins. Do you have any experiences about that? Statins and side effects
Muscle
among your
pain.
patients? Yeah. When we use very high doses, it's very common. So there was a recent guideline of United States Preventive Task Force. It also again came to this cardiovascular risk assessment thing. Therefore, I thought of introducing that WHO cardiovascular risk assessment chart. When we put this cardiovascular risk assessment chart uses total cholesterol level. So in Mr. HG, we had total cholesterol level, which was 158. It's about more than 4 millimoles per liter when we convert it. And he's at the age of 60 to 64. He's a non-smoker, male, and his blood pressure was in the 120 to 139 range. So his cardiovascular risk was 11, and that is 11%. So that means if we take 100 people with Mr. HG, then 11 will get the cardiovascular morbidity within the next 10 years. That's how we interpret the cardiovascular risk. And the third part I want to emphasize in this presentation is the documentation. The proper documentation would have guided Mr. HG as well as his doctor to improve the outcome of his management. Simple format, which is less time consuming, and the format can visualize trends and reminder for management steps. So this document is actually used in Faculty of Medicine Ragam Family Medical Clinic for hypertension and diabetes. It says blood pressure, fasting blood sugar, weight, and we use this kind of format per year, and we put the name of the month and then tick off, and in the lower part we are writing the drugs. So we can easily paste the printout like this. I prepared this later based on that chart, month and date, as well as osmotic complications, micro, macro complications, drug compliance, diet compliance. If we give that, we can put a tick. So we know that we have given. It's very important and legally very valuable that we have marked, we have given the advice to the patient. And body weight, blood pressure, those few things we will not miss in management, chronic management of a diabetic patient. And also a part for annual screening, eye screening, foot examination also. So I think as GPs, it's advisable for us to maintain a chart like this. So at the end of my presentation, the take-home messages are regular monitoring, optimal treatment, and target-oriented management. This is the key for good management of diabetes. And we need frequent compliance boosting advice. And we have to monitor, we have to frequently set the next visit. If we can write down the date of next visit in the patient's book, it will remind him to come. One of my consultants I worked under used that. He put a 1 week, 2 dates. You have to come within this week for the next visit. He was a obstetrician actually. in the antenatal visits, he put a 1 week gap for the patient to come on any day. And he gives a priority for the patient to book his channel if the patient comes on that day. So that was one good way of maintaining the regular follow-up. And the third point I want to emphasize is sudden onset of symptoms. We have to maintain more attention, and we should not miss strokes or tumors if the patient comes with headache, and it may be detrimental to the patient. And fourth thing is the summary chart to the patient's clinic book. It will ease your workload as well as it will improve your compliance. So these were the references I used. And I would like to thank especially my teachers, colleagues of Spice Route, including Dr. Shamin, Dr. Manoj, and Dr. Gobit, as well as Dr. Deshan Kotukodella, my registrar in my senior batch, and also Dr. Chain Halpe, my colleague, for giving me good inputs for the preparation of this slideshow, as well as Dr. Gayatri. So thank you very much.
Thank you, Dr. Prabhath. That was very informative. And to be honest, when you spoke about your topic, a bus driver who cannot overtake, I was actually wondering whether he's going to fly, because they're the most dangerous people you can encounter on the road. But today was very informative, and to know about especially the primary prevention and the documentation. I really, on my perspective, it was very informative. So do we have anyone else who would want to talk about something or discuss? Okay, we have something on the chat box. So we've got this question from Neil Jayanthan, who's asking emergency management of stroke at the GP level before we send the patient to further care.
Yeah, I think, as I said earlier, this patient is like a book. We could have studied his case in many aspects, many views, and I chose specifically 3 aspects. And acute management is another aspect we have to consider, and we have to know thoroughly in managing patients like this. And so when a patient presents with stroke, I think the most obvious stroke presentation is hemiparesis. What we miss is the things like this: headaches, some cerebellar signs, sometimes diplopia. We are not suspecting stroke in those patients. It's very difficult at once to think of this, because in the case of diplopia also, usually almost all of the diplopias are sudden onset. Patient present suddenly, maybe a stroke, maybe even a tumor. The patient comes like it happened in 1 or 2 days, because once patient feels that, patient can't stay home. So if we suspect a stroke, there's time interval, time target to ideal management of stroke, door to doctor time, then access to neurological expertise. We have to think of whether it is a ischemic stroke or hemorrhage, and we have to actually send the patient soon to the nearest center where imaging studies are possible. And for that, as GPs, we have to ensure airway, breathing, and circulation is not compromised. And then we have to arrange transport to the nearest center as soon as possible for the management, specific management. So Actually, you all can contribute to that.
So do we have any more inputs from anybody else?
Dr. Prabhath, thank you so much for the wonderful talk. Also, I think as GPs, we should know, by hand, by heart, or like we should know the information where exactly refer, because we don't have many PCI or stroke centers in the country. So sometimes it depends on where we send the patient as well. And some patients are really lucky to recover from the stroke then and there, but some some are not so lucky. So I think we all, it should be circulated among, I suppose, the general practitioners when we come across these patients, where exactly to refer, say even for acute coronary syndrome, because we don't have many PCI centers, isn't it?
Yeah, actually speaking, I have to reveal this because this patient was not first seen by a general practitioner. On the second day, there was a patient delay. On the second day, he went to a specialist, and he has given some treatment and sent patient home. So then about 3 days later, he again went there, and he was referred to a eye surgeon. That's what happened. And eye surgeon referred him to a neurologist. So it was not mainly the GPs who managed him in that case.
Okay, thank you, Dr. Prabhath, once again. So if you do not have any more questions, we would, on behalf of the Spice Route Sri Lanka and the College of General Practitioners, we wish to present this certificate to Dr. Prasad for Prabhath for being here as a resource person today.
Thank you.
One moment. There's a small problem in sharing.
Yeah, wait a minute to share it. Yes.
Yes, we can see that now.
Thank you very much.
If
Thank you.
possible, we will
Finally,
try
I
to
would,
give a printed one. Yeah.
Finally, I would like to invite Dr. Maldika Pereira, the Secretary of Spice Route, to end this session with a vote of thanks.
Thanks, Shamin. It's a privilege to share a vote of thanks as Secretary of Spice Route Sri Lanka. At first, my sincere appreciation and thanks to all audiences who joined via online. It was a really interactive session with your participation. Moreover, our special thanks to Dr. Prabhath Nanayakkara, who is the resource person for today's GP's Café. Dr. Prabhath, you really shared an important case in an impressive way. I will take this opportunity to thank the College of General Practitioners of Sri Lanka for all administrative and collaborative support for this session. And also, it is a pleasure to inform you that we have our own YouTube channel, the Spice Route Sri Lanka.
Yeah, I'll share it. Yes.
There are about 20 videos, including previous presentations of GP's Café. By using this QR code, you can join with the YouTube channel. Thank you very much.
Yeah, we will share it. Also, we will, if anyone willing to join the Spice Route, we will send the application also. So anyway, we welcome your suggestion and comments, and we hope to meet every month. Say any interesting case you can be presented and we can discuss. So actually this may be the fun, maybe we can learn it with the discussion and as well. So please come forward and join with the case discussion. Thank you.
Thank you all. I hope you all have a good night.